Good afternoon. We are witnessing 2937th lecture of our esteemed Bangalore Science Forum today. With pleasure, I welcome the President of National Education Society, Dr.HN Subramanya sir. I also welcome the Vice President of National Education Society, Shri Manjunath sir. The Honorary Secretary, Shri Venkat Sivareddy. Principal Dr. Y.C. Kamala. Vice Principal Dr. Ramesh. A hearty welcome to Dr. Samarth Arya, a young yet highly successful orthopedic surgeon who is here today to enlighten all of us. Dr. Samarth Arya is a highly motivated and compassionate Indian board-certified orthopedic surgeon with extensive expertise in manual and robotic primary and revision, hip and knee orthoplasty. As a consultant orthopedics, joint replacement and robotic surgeon, he has performed over 600 robotic joint replacement surgeries, including total hip, total knee, and partial knee replacements, utilizing the Mako Striker robot. Dr. Arya holds robotic certification from Cambridge, UK, distinguishing him as one of the few surgeons in India with UK-associated NHS certification. He completed a dedicated 12-month fellowship in robotic joint replacement from the NHS in the UK. His audit contributions and published research showcases his commitment to improving orthopedic practices. Dr. Arya's educational background includes MCH Orthopedics with specialization in trauma and orthopedics and hip and knee. He also obtained a diploma in sports medicine from the International Olympic Committee in September 2023. With a wealth of work experience, including a senior clinical fellowship in lower limb arthroplasty and revision and robotic hip and knee arthroplasty at Woodend General Hospital in the UK. Dr. Arya has been contributing significantly to the field, currently serving as a consultant orthopedic, joint replacement, and robotic surgeon at Manipal Hospital. He previously worked at Spurge Hospital, Infantry Road. Dr. Arya's dedication to excellence in hip and knee arthroplasty and robotic surgery is evident through his clinical achievements and continuous pursuit of knowledge. I'm immensely thankful to Dr. Arya for being here today, and again, a warm welcome to you, sir. So a warm welcome to all of you present here today. Thank you.
Front and back. The front. Laser marker. Laser. Front. Sorry.
Thank you very much. I would like to thank the National Education Society, National College, and the Bangalore Science Forum for giving me this wonderful opportunity to present the work we do at our hospital. My name is Dr. Samarth Arya, and I'm a consultant orthopedics joint replacement and robotic surgeon at Manipal Hospital, Old Airport Road. Today I'll be speaking about osteoarthritis and the very latest tool in orthopedics, that's a robot for joint replacement. First of all, let's start by knowing what is osteoarthritis. So basically, when two bones come together, the formation of a joint, there is cartilage in between the bones so that there is smooth movement between the bones. Otherwise, what happens is two bones when they articulate, it causes a lot of friction because bone is a hard substance. So this cartilage acts as a cushion between the two bones and causes smooth, slithery movement of joints. However, what happens is with age, as this cartilage is made up of water and protein, there is a change in the composition of the water and protein, and the cartilage, which is supposed to be smooth and slithery, starts becoming hard. So with each cycle of movement, there is a plaque of cartilage that wears off, and due to this wearing of cartilage, the patient starts to get osteoarthritis. So this is primary osteoarthritis. There is something else called secondary osteoarthritis, means arthritis due to some other problem. This can either be because of trauma, that is injury to the joint before, which causes depletion of the cartilage, or also some systemic problem like rheumatoid arthritis, psoriatic arthritis, which causes early wear and tear of cartilage. So this is secondary osteoarthritis. But as a whole, in osteoarthritis, what happens is the cartilage wears off, which results in exposing of the raw end of the bones, which means the nerve endings are exposed as well. As a result, the patient starts perceiving pain. So what happens in this is, initially patient starts getting pain, then they have swelling around the joint, and then they start experiencing stiffness. Because of all this, their activities of daily living takes a major blow. So how do you avoid arthritis? There are a few steps to keep yourself mobile and healthy. First is regular exercises. This reduces wear and tear in the joint, which means a well-oiled engine which is routinely used is a healthy engine. Same thing with our human body as well. So movement of the joints reduces the joint stiffness, which means lesser pain and improvement of muscle strength, and this also helps us maintain a healthy weight. So second point here now is ideal weight. It is quite crucial to maintain a body weight which is proportional to the physiology of a particular individual, because excess of body weight means excess stress on the joints, which means further wear and tear of the cartilage. So if you have an ideal body weight, the stress acting on the joint, especially the lower limb joint, that is the hip, knee and ankle, is lesser, which means there is lesser wear and tear. The next thing is low impact exercises. Why do I use the word low impact? Because it is important to do exercises such as walking, jogging, swimming, maybe even trekking. But what happens when you do high impact exercises like jumping or trampoline and things like this? As I mentioned, in an individual after the age of 45, the composition of the water and the protein in the cartilage changes. So when these are subjected to high impact exercises, the wear and tear of the cartilage increases, which means the person starts experiencing osteoarthritic changes. So it is important to respect the physiology and your age and do the exercises accordingly. So low impact exercises are quite crucial. Strengthening of the muscles. So once you strengthen the muscles around the joint stays healthy, because the muscles make sure that the bones are kept apart and the healthy cartilage is maintained. So weight training is quite important. So improvement of the stability of the joint reduces the pain. Even in early stages of arthritis, we send the patients to physiotherapy and help them strengthen their muscles. This is basically to reduce the pain. And range of movement exercises. So keeping your joints mobile and supple is quite important to avoid stiffness, which means there is good circulation in the joint. And if there's good circulation of the synovial fluid, which is the fluid in the joint, it means the individual has a healthy cartilage and low risk of osteoarthritis. The other crucial factor is vitamin D and calcium. This is important for bone health. So stronger bones means stronger joint and a healthy joint. So it is quite important to get your levels of vitamin D, calcium and B12 checked time to time, because if there is deficiency, this can be treated earlier and we can avoid the risk of osteoarthritis. Then other habits like smoking are associated with increased risk of arthritis. This is because of associated bursitis and tendinitis around the joint, which can impact the joint. So this is a picture showing how the articular cartilage sort of wears off and how the arthritis progresses. So in the first picture, you can see this is a healthy cartilage, but however, the thickness of the cartilage starts reducing initially. and then you can see bits of bare bones. So it's basically like paint, sort of the plaque falling off a wall. And what happens is that disease progresses and starts increasing in size and involving the entire joint, and that is where sort of most of the raw bone is seen, and patient has severe pain and deformity. So there are several options to treat arthritis. The first one is analgesics or painkillers, basically anti-inflammatory medication. So this has a temporary effect, maybe a couple of hours or maybe even up to a day. And these are helpful in early stages of arthritis, because taking painkillers for long term is not good, as these painkillers are excreted out of the body either through kidney or liver, most of them. And taking them long term can cause insult to the kidney or liver in the individual. So analgesics are sort of a temporary measure and are good for early stages of arthritis. Same thing with physiotherapy. As I have mentioned, exercises, low impact exercises and range of movement exercises are good. But again, these do help for a short term, and especially in the early stages. But once the patient stops doing them, the pain sort of comes back. So it is important to stay healthy and continue with these exercises. The next one is injection. There are several options. One is steroid injection, which reduces the inflammation in the joint, but however, it is not ideal to take repeated steroid injections. The other option for injections are PRP injections or growth factors, where the patient's own blood is drawn and centrifuged to isolate or take out the growth factors, and these growth factors are injected back into the joint. So this sort of is a temporary stopgap procedure, which it doesn't exactly form the same sort of cartilage that is God given, but it forms some sort of a bridge temporarily. The other option, the latest option, is stem cell therapy, which is still not proven yet, but that is an option as well, where you take out the cartilage from an individual, put it in a lab, multiply the cartilage cells and put it back in the individual. The last option is surgery, which most commonly is used in end-stage arthritis. That's the grade 4 arthritis I was telling you about. So there are several surgical options like realignment procedure. So what happens in end-stage arthritis is, because of the deformity of the joint, the arthritis starts progressing very quickly. So there are several realignment procedures where you try to make the leg straight. But however, in these realignment procedures, you're not still removing the diseased tissue, but you're sort of giving a patchwork treatment. Apart from this, there is arthroscopic surgeries, again in maybe grade 2, grade 3 arthritis, where the cartilage is sort of partially worn out. You can put a camera and remove the fibrillated cartilage. And in arthritis, again, what happens is, because of the wear and tear, there is generation of pain-causing substances which start circulating in the fluid. So by doing arthroscopy and washing it out, they do get temporary relief for a few months. And what is the sort of a definitive procedure is joint replacement surgery, especially in end-stage arthritis, where the cartilage is completely worn out. You remove the diseased joint and replace it with an artificial substance, about which I'll be talking shortly. So now let's move on to joint replacement, also called as joint arthroplasty. So what determines the long-term results of this surgery? There are two important factors. One is restoration of the accurate biomechanics, means bringing back the joint to where it's supposed to be originally, because with progressing age, the deformity or the structure of the joint starts changing. So you want to bring it back to normal, what was in the same patient maybe 20, 30 years ago. So that is restoration of the biomechanics. And placement of the implants, that is preparation of the bone and how the implants go in. You have to make sure that these implants are placed in absolutely accurate position for the longevity to be increased, means for a longer lifespan of these implants. Insufficient precision and reduced accuracy means there is impact in the long-term outcome of these surgeries, which results in failures and complications. So normally what we do is, be it a hip replacement or a knee replacement, we have conventional jigs for the knee replacement, which gives us a ballpark figure, and we sort of measure angles from that and we carry on the surgery. When it comes to hip replacement surgery, we go with eyeballing, as in sort of look at the soft tissue and assume, okay, this might be the right position, and go with it. But what happens in improper implant positioning is chance of complication increases. chance of implant failure increases. So this is where computer navigation came into play. So computer navigation is again of two types. One is just a navigation where you sort of get a guidance. The second one is robot, where you actually have a machine that helps you operate. So these are the two different types of computer assisted surgery. So let me speak about the navigation first, which is sort of phased out from the market now. So this is basically a screen attached to the conventional jigs, and this sort of gives us readings. So this was helped with, used with surgical planning, and this did improve the accuracy to a certain amount. But what happened is you were sort of looking at the monitor and operating, and it did not give the surgeon any feedback in case he was doing any surgical error. He didn't get a feedback, he or she didn't get a feedback to say, hey, stop, look, you're doing something wrong, stop, you need to correct yourself. You just keep looking at the screen and operating, and so there was no real-time, feedback, and this sort of phased out of market, and this did result in a few complications as well. So this is where the robotic arthroplasty or the technological revolution into robot came into play. So this robots are basically a mechanotronic device, which means the device is there, electronic device there, and they're also mechanical. So the surgeon is using the robot to operate, where they get visual, tactile, and sensory feedback. So you're seeing also, you're looking at the screen also, you're getting a feel of what is happening, and if you're doing some error, the robot stops or makes a sound. So this improved the precision of bone preparation and placement of implant. And with a robot, the biggest advantage is you use the real-time data, as in during the surgery also you get a feel of what is happening, and on table you can do correction of your measurements or implant alignment. So what are the advantages of robotic arthroplasty? First is the size of incision goes down considerably, because you don't need to see the whole joint, you just need to see part of the bone you're preparing and part of the implant that needs to go in. So size of the incision definitely goes lesser. Because of all these factors, the blood loss is lesser, which means the post-operative pain is lesser, as you have, the amount of soft tissue release required to sort of, bring back the joint opening to put the implant in is lesser in robot. So there's lesser post-operative pain, which means the patient needs to stay for lesser duration in the hospital and gets to go home earlier. There is early recovery and return to normal daily activities much quickly. Because of the precision and the placement of the implants, especially in a hip where the cup is perfectly placed, the chance of complications such as dislocation, which is most commonly seen in a hip replacement, the ball coming out of the socket, is almost zero with a robotic hip replacement. Then restoration of the limb length. So, you have these guides which show you if the limb you have repaired is either longer or shorter, and the accuracy you get is up to 1 millimeter, which a human eye can't even see. And safety, this is what I was telling earlier about. The safety is 100%. So in this robot, what happens is it has a haptic boundary, which is a virtual boundary, which you can't see on table, but you can see on the screen. So when the saw or the reamer touches these boundaries, the robot stops. So the chance of damage to ligaments, muscles, artery, nerve is almost nil. It never does happen. Even if the surgeon intentionally wants to damage these, it won't let you do it. So there is almost zero risk of injury to adjacent tissue, and longevity of these implants is massively improved because you're placing the implant in the perfectly accurate 100% accurate position in every case. So if you're doing perfect placement in every case, the average of the implants naturally goes up. So these are the components of the robot which we use. This is the visualizing system, basically called the robotic eyes, which sees where the robot is and where the limb is. This is the robot per se which we utilize to do the surgery, and this is the console which is used by the product specialist of the company. He sort of inputs all the numbers and instructions we given for the robot to follow. So first, let me speak about hip replacement surgery and how a robot helps in it. So in hip replacement surgery, in the hip joint, we change the cup and the ball. So when we change the cup, we use a metal cup with a liner. It can be a polythene liner or a ceramic liner. And when we change the ball, we also use a stem along with the ball. Again, the ball is made up of different materials like metal or ceramic. So what happens is, when we do it in a conventional way, when we are putting the implants, we go with an eyeballing on an average based on, okay, this looks right, this looks stable, and we insert the implants. But what happens with a robot is, I mean, with all robotic cases, we get CT scans, and these are, the bone mapping is done. And then these, the plan is fed into the robot, and then we carry out the surgery, which I'll be explaining shortly. So we get 3D CT scans, and based on these plan, either preoperatively or intraoperatively, surgeon can do dynamic monitoring. So even before the surgeon or the patient enters the theater, we already know how the implants are going in, what size of implants are there, and how the X-ray will look after the surgery. Imagine having an X-ray of a patient even before the surgery is done. That's what the robot does. So even before we enter the theater, we already have a post-operative X-ray in hand. No matter how big a hospital you work in, there is always some sort of deficiency in size of implant, because there are so many different size of implants, so many different types of implants. So what happens with the robot is, you already know the size of implant required before the surgery. So you can make sure that that particular implant is present in your armamentarium even before doing the surgery. Because as I told, no matter how big a hospital you are, these company people, when you're doing the surgery and you ask for a particular implant, the company person often says, sir, apart from that one size, all other implants are there. So this sort of becomes nil with a robot. You sort of already know the implant you're going to use. So this is how a robotic hip replacement works. A quick video to demonstrate. We get the CT scan of the patient to understand the bony anatomy of how the pelvis is, how the hip joint is, and how the femur is. All this planning, what is being shown here, is done before the surgery, before the patient enters theater. So we have gotten a CT scan. Now we know how the implant needs to be prepared, and how the cup goes in, and how the stem goes in. So you can see that how the X-ray is and how the implant will be placed. So based on this, we can do real-time monitoring. And now the patient comes into the theater, we open the skin muscles and go to the bone. We do registration of the bone to understand how the head of the hip is and how the acetabulum is. And based on that, so this is how the registration is done. It's about 40 points on the cup side and a few points on the neck and the head side. And once we do that, we do confirmation of the points. So you can see the error here is less than 0. So when we do registration, it goes to less than 0 or 0.1. So that is the level of accuracy you get. Now all we do is bring the robotic arm in and start reaming the cup. Normally in conventional, what we do is serial reaming. Start from the smallest size and keep increasing the size of the cup till we get a good fit. But here we already know the size of the cup. So all we are doing is reaming, and you can see that part of the bone being taken out. And it doesn't ream any extra bone than what is required for the implant to go in. Once that's done, again we attach the actual cup to the robot, and that places the in the required position, and you hammer it in. Done. Surgery is done. Quite quick and accurate. The advantage of robotic hip replacement is taking into account the position and relationship of the spine and the pelvis, which doesn't happen with a conventional hip replacement. So if the patient has a stiff spine, either be because of previous surgeries on the back or because of spondylitic changes in elderly, what happens is the pelvis becomes stiff, which means if you don't have a good spine-pelvis relationship, when the patient tries to do extreme movements, the ball comes out. But in this, what happens is you calculate the spino-pelvic relationship, make sure the cup goes in the perfect position, such that you place the hip in extreme of movements and still it stays stable. So you make sure that the hip doesn't dislocate even in extreme of movements, based on the relationship of the pelvis to the spine. So all this is the planning that happens before the surgery. You have accurate placement of the implant, and this you can monitor as per and alter as per the requirement of the patient. So that's how it looks. And look at that. That's the X-ray of the patient even before the surgery is done. We already know how it looks, and that's how it looks in real time. So this is an X-ray of a patient we did a bilateral hip replacement on. No matter how experienced or a senior surgeon does a hip replacement, it is very unlikely that both the hips will look like a mirror image, and the length in both the hips is absolutely accurate. But here is one such, hip replacement done with a robot where it's a perfect mirror image. So you keep a mirror in between, this will look exactly like that. And it's almost the same size of implants. So that's what a robot does. Be it a junior surgeon, senior surgeon, a trainee, they will be able to do 100% job in every case. That's the advantage. Next is a total knee replacement. Again, here we do a 3D CT scan to understand the bony anatomy, and we plan the implant placement and preparation of the bone. So what happens in knee replacement is, apart from the bone, the knee is surrounded by ligaments, which opens the joint. So intraoperatively, you assess how much of this joint opening happens, and based on that, between the two metal surfaces, you have to place a poly, that's a plastic. So we accordingly calculate the size of plastic and place it in. So there's again a video to understand how a robotic knee replacement happens. First, we get a CT scan of the knee joint to understand how the thigh bone and how the leg bone are. Once we know the ends of the bone, we do the same registration like the hip joint. So this is the calculation. You can see the planning happening even before the surgery is done. So we know already the size of implants, the size of poly, and what position it goes in. All the measurements are already there. So absolutely perfectly planned and perfectly placed implants. So once this planning is done, now we take the patient into the theater, open up the joint, and do a quick registration for the robot to understand where the end of the thigh bone is and where the end of the leg bone is. That's about 40 points on the femur and 40 points on the tibia. That's how it goes. And you can see at the end of this, the outlier is about 0.1 or 0.2 millimeters, which is almost negligible. And intraoperatively, you see how much the ligaments on either side opens up. You can see that either closes or opens. That's a dynamic number. And based on that, you plan your poly. So this is the haptic boundary I was telling you about. On the robot, it's already marked. So with the saw, when we are trying to touch the boundary, the saw stops. So you can see here, it's just going along the boundary, and any ligaments there, artery nerve there, or ligaments here, it doesn't even touch that. Even if the surgeon intentionally wants to go there, it never happens. The robot would never let you do that. So that's how you prepare a bone. And once that's done, you have a perfect prepared bone for the implants to go in. The surgery is done. So that is the registration of the femur, the tibia, the planning. The most important, most common complication in a conventional knee replacement is overstuffing of the kneecap, where the implant goes beyond the normal bony boundary, and as a reason there's a lot of overstuffing of the kneecap or the patella. So here, even before the surgery, you can make sure the implant is well placed under the bone so that there's no sort of stretch of the kneecap. So based on the ligament balancing, you get back the numbers, and then you try to get as almost perfectly balanced knee joint. So that's how a robotic knee replacement looks. We attach arrays and open the joint and do real-time balancing and place the implant. So this is an X-ray of a patient we operated on with severe arthritis, and you can look at the soft tissue component. So she's a massively obese patient with a lot of adipose tissue around her bone. So what happens in these patients is application of the conventional jigs, because the bone, tiny bone is sort of enveloped by a large fat tissue. You can't really bring the jigs towards the bone. But in a robot, you don't have these jigs. All you need to do is registration of the bone, and the robot does all the bone preparation. So that's her with a perfectly placed implant, and the surgery lasted less than 30 minutes. So with a conventional trying to put these jigs, trying to expose, make a big incision, none of that is required here. Just you can see the size of the incision. It's only for the implant to go in. But if you do a conventional, it will go somewhere from there to there, for the whole joint to be seen. This is another badly arthritic knee. You can see the subluxation front and back, quite a lax joint with lot of osteophyte formation, extra bone formation. So we, sort of brought this bone back, and now it's a straight knee joint. So this is the same patient 1 week after the surgery. So she's taking baby steps and trying to get back to normal. Normally in a conventional knee replacement, we use walker for about 3 to 4 weeks. Here she has already sort of discarded the walker because she started feeling stability in her joint. And now that's her 3 weeks post-op, walking quite briskly, almost like a normal patient. and the smile on her face says a lot. The last one is a unicompartmental knee replacement, which means we are replacing only part of the knee joint that is affected, not the whole joint. Earlier, this operation has been there around for some time, but what happens is getting the accurate alignment and placement of the implant. This is a challenge in partial knee replacement. As a result of this, the revision rate, as in the need to do revision implant placement, is about 7 to 32%, which is a significant revision rate for a joint replacement surgery. As a result of this, not many surgeons prefer to do it, and only few surgeons, specialized and specialized centers, would carry this on. But now what happens with robot is you get the real-time images and any surgeon can do this surgery. So the probability of component malpositioning, malalignment or ligament imbalance becomes zero with robot. Again, a quick image to show how a robotic partial knee replacement or a unicompartmental knee replacement works. Very similar to the total knee replacement, we take the CT scan and feed it to the robot so that the robot knows how the anatomy of the bone is. And again, before the surgery, we do the implant planning as to how the femur component needs to stay. And I'll just tell you a few parameters in a while as to what all we see. And based on that, we can always alter the position and the size of the components, be it the femur or the tibia. Once that's done, you can see the size of incision. You don't even need to see the whole bone. You just need to see the part of the joint where the implant needs to go in. In a normal partial knee replacement, the incision goes from there to there. But in this, it's quite small. So based on that, you do a registration of the femur first, followed by registration of the tibia. This is basically for the robot to understand where the joint is. So once that's done, we bring a burr in to shave off the part of the bone for the implant to go in. So we are just removing the part of the bone which needs to be taken out for the implant to go in. So the green part becomes white, and in case we remove excess bone also, it shows red. So what is red? Red is basically 0.5 millimeter extra bone taken. So it hardly won't make any difference. Once we burr out the bone, all we do is place the implants, place the poly, boom, surgery is over. So these are a few parameters we usually look into partial knee replacement, which the surgeon wants 100% accuracy in, like the slope of the implant and making sure the front and the back of the implant is accurately hugged by the bone, and making sure this eminence where the ACL attaches is not injured. So so all this planning is done before the surgery, so you can make sure the implant ends right before that eminence and it goes all along the bone there. So it is perfectly sized, not oversized or undersized, and the PCL is left free as well. Same thing with the femur, you can make sure it is placed straight and it's just underlying the bone. The curvature on the outer side is hugging the bone and it's absolutely in the center. It's not either this side or that side, it's absolutely in the center. So this is a case where we have done. You can see the most common complication in a partial knee replacement is when you're trying to replace this side of the bone, you overstuff it, which means this is under pressure. But here when we do a partial knee replacement, we just restore the gap without altering this gap. So whatever gap was there preoperatively is maintained postoperatively, and the gap that was absent has been recreated here. So in conclusion, what happens in robotic knee replacement is the improvement of the precision and accuracy. It's almost 100%, which is almost impossible to say in a conventional joint replacement surgery. This allows the surgeon to master the key skills. It is minimally invasive, as in the size of surgery becomes small. It's not a keyhole, but the size of the surgery is considerably small. And patient satisfaction is higher because any patient who can go back to their routine sooner than later is always happier. This improves the overall efficiency, be it when the patient is in the hospital or even after they go home. And there is an added cost for using the robot, which is basically the consumables we use to use the robot, be it the robotic drape or the robotic saw or the robotic sensors. So that is the cost that gets added. But what happens, there are studies projecting the extra cost over 5 years. The rate of readmission of the patient back into the hospital, be it because of need for revision surgery as an implant malposition or because of stiffness where they need physiotherapy, when you project this cost over 5 years, the use of robot sort of nullifies all this, and works out much cheaper. So these are my gurus in Aberdeen, Scotland, who trained me in robotic hip and knee replacement. That's Mr. Andrew Johnston there, and that's Mr. Stephen Hamilton. So whatever I know today in the world of robotic is because of them. They helped me see robotics. And I'll be on TV9 tomorrow for an interview for the same robotic joint replacement. This will be in Kannada, so if you're interested, you can just tune in between 1:30 and 2 p.m. in the afternoon. Thank you very much. My contact details there, so feel free to contact me. Any questions, I'm open to take.
Thank you, sir. Your talk was very informative and useful for all of us here regarding that robotic joint replacement. I think it is a new adventure in the field of surgery. I think it is very essential, and this doctor is also having a good future in the coming days. So on behalf of Bangalore Science Forum, on behalf of our management and college and staff members, we extend sincere thanks to you for your wonderful delivery talk. Thank you, sir. Now, open for questions. Yes.
Thank you, sir, for this amazing lecture. It was very good. So we got to know more information about robotic joints replacement surgeries. So my question is, why does it focus only on arthritis? Is there any other physical
Ajit?
conditions where we can use this?
The robot?
Yeah.
Yeah, so basically joint replacement surgery is used for arthritis itself. So that is the primary indication where the cartilage surrounding the ends of the bone is worn out, and patient starts experiencing pain, stiffness, and their routine activities is affected significantly. So that's where we replace the joint such that we remove the diseased joint and place these artificial implants and recreate the normal joint. So that's why it is used only in arthritis.
Okay, and my second doubt is, it mostly focuses on the curved surfaces.
Yeah.
So
yeah.
what if it is a sharp-ended surface?
As in the joint is curved, isn't it? Like knee joint, suppose it causes the hinge movement. So it is a curve.
Yeah, if there is any accident or if there is breakage of bone, which
So fracture, we
leads-
can't use robot in trauma.
Okay,
We
so
can't use
that's-
robot in trauma.
Okay,
Unfortunately, that technology is not available yet. Robot is now available in orthopedic practice. It's available only for hip and knee joints, but there is extensive research going on for shoulder joints as well. For spine, robots have come in, and the other use of robot is in the field of gynecology, oncology, oncosurgery, then urology, so and general surgery. So these are the other divisions of medicine where robot is being used. But for fracture, it's not available yet. So once the bone is broken, you can't do a registration, you can't get a real-time image because the translation moment is lost once the bone is broken.
And my final question, sir. So when you're talking about stem cell, I
Yeah.
just got to know about the thing which is
Yeah.
called grafting. So is there anything which you could do with grafting of cells?
So there is option of if the lesion in the cartilage is isolated, what they do is they take the patient's native stem cell, grow it in a lab, then sort of use a cartilage or a sheath to cover the defect and inject the stem cells into that and then suture it off. But that is only for localized lesion in young individuals,
Okay.
not for adults with generalized wear and tear.
Old
If it's
age.
only localized,
Thank you so much, sir.
no problem.
So how does one deal with post-operative pain?
Right. Excellent question, actually. So it is very important for the patients to understand what the surgery is and what happens after the surgery. So the patient needs to be in the hospital for about 3 to 4 days after the surgery, basically to get over the pain. Then the staples we put will stay on for about 2 weeks, and that is important, because the wound has to be dry for that duration. They can't get it wet. It has to be completely dry, and the staples or the sutures come out after 2 weeks, and then they can go to a shower. Now this surgery, joint replacement in arthritis is only 50% of the treatment. It's not 100% treatment. So what the surgeon is doing is taking out the diseased joint and putting an artificial joint. So now the other 50% and the more important 50% is over to the patient. They have to do physiotherapy to regain the movements and to strengthen the muscles, which the surgeon can't do. The surgeon has cut open the muscle, put implants, closed it back. Now to get back the strength and get back the range of movement is over to the patient, which they have to do for a minimum of 4 weeks, and they have to do it religiously. There is no skipping. They have to do it every day for 4 weeks to regain the movement. So once they get the functional movement, they can sort of go back to their normal activity. Most commonly asked question is, can I go back, can I get full movement? On table, when we are operating with a robot, we calculate how much movement they get. So invariably, in every case, we target 120 to 130 degree bending of the knee, which is more than required for a patient. It's almost near normal. After the surgery, if the patient can regain that movement, they can sort of go back to most of their normal activities, be it doing yoga, sitting on the floor. Maybe the one thing they can't do is sitting on Indian toilets, because a lot of stress is acting on the implant. So that is one thing we ask to avoid. But they can go back to running, jogging, swimming, trekking, sort of any sort of dancing, even playing sports, tennis. Most of them go back to normal activities. And especially with robot, the accuracy is so much and the recovery so early, they do much better. So as I told you, conventionally we ask the patient to use walker for about 3 to 4 weeks, and then maybe walking stick if required. Here also we do the same. It is not a competition, but the patients tend to go back to normal sooner.
Thank you, sir. Can the pain extend up to 2 to 3 months, sir?
Yes, it can. So the patient would have lived with this diseased joint for large amount of their lifespan, like 60, 70 years. Now suddenly we are putting something new. So for the body to recognize that it is their own joint and it's a normal joint, takes anywhere between 6 weeks to 3 months. For the swelling and all to reduce can take up to 6 months to 1 year. But by the end of 6 months to 1 year, they sort of, most of them go back to normal.
Thank you, sir.
Any questions?
Yes, sir. Thank you, sir. Wonderful talk by you. Is there any limit on the bone density to make it brittle?
Yes, sir. So bone density, I mean, we have the Z score to calculate whether it's osteoporotic or osteopenia. Osteopenia means going towards weakness. Osteoporosis means become spongy and weak bone. That one, I mean, there is, it is related to arthritis, but there's more of a bone problem where, we give supplements. There are different sort of supplements to strengthen your bone. So osteoporotic bone are more susceptible to fractures than arthritis. But yeah, there is a relationship between osteoporosis and
Then is it only the calcium that causes problem, or
calcium,
other minerals?
vitamin D, vitamin B12, they're all linked, sir.
All linked.
You cut off one, the whole thing, the whole chain breaks.
Okay. Thank you, doctor.
It is a free consultation. So tomorrow onwards, you can't meet the doctor. Please ask any of your doubts.
And my number is there, so you can always contact me.
Thank you, Dr. Samarth Arya.
Oh, I think one more.
Yeah, please.
How to make out in early stage that someone is facing with this problem? Like
Yeah.
if it's not there in some starting stage,
Yeah.
pre-stage, how someone can make out that if the person is facing with arthritis or something?
So, as I told, the symptoms of arthritis is pain, stiffness, reduced movement. So, suppose, let's consider knee. The patient starts noticing pain climbing stairs, getting downstairs, trying to sit on floor and get up, or trying to sit on chair and get up. And they have, this sort of dull aching pain towards the night and early morning pain. All these sort of indicate arthritis.
Like precautionary measures they can take at starting time,
Low impact exercise and physiotherapy, range of movement exercises.
like any diet.
Diet is just to maintain weight. So, I mean, you do have supplements to help your cartilage, but in early stages it does tend to help, but in a full-blown arthritis it doesn't. The reason being, cartilage is avascular. If you get a cut on the skin, it heals up well because there's blood supply. But in a cartilage, there's no blood supply. So once it's worn out, it's gone for good. It's like tires of a vehicle. Once they go bald, they need to be replaced.
Okay, and which the metal plate is like stick on the knee.
Yeah.
So it is also like a type of metal. So it
Right.
also,
Yeah.
like generates some friction, right?
Exactly. So we are not causing two metals to articulate. There is an articulating surface, that's the poly I was telling you about. So obviously there is third body wear. That is the reason we give a lifespan for each implant. With robot, we say it's about 25 to 30 years, after which it definitely needs a servicing, like any vehicle. It is not a natural joint. So when the metal articulates, be it with ceramic, plastic, there is wear and tear. But these things, we try to get accurate alignment, and these are subjected to cycles in the laboratory under ideal conditions. Like telling the mileage of this car is 17 kilometers per liter when it's run ideally, but that doesn't happen. You're changing air and mileage drops. Same thing with this. The company claims it's about 25 to 30 years, but if used ideally, it should last that long.
What are the possible disadvantages
Of robotic. Me being a robotic surgeon, I would say nil, but appropriate training is very important. The person who's using a robot should know how to use a robot and when to use a robot. Most of the patients who are suitable for a normal joint replacement are more or less good for robotic knee replacement. In fact, the advantages will become more. Be it medical complications, surgical complications, everything is reduced with robotic. The chance of damage to soft tissue, artery, nerve, everything is reduced. The only condition where you can't use a robot is if the ligaments are already torn because of any injury or because of overstretching. If the ligaments are torn, the robot can't balance the ligaments because the whole principle is based on balancing of the ligaments. So if it's torn, it's basically you've taken one hand away. So there is no support to use a robot. That's when we use something called constrained, semi-constrained implants, which a robot right now cannot support, but maybe in the future.
Dr. One question. A person is habited to walk 6 to 8 kilometers a day for some time, or for a long time. Some people discourage him saying that, don't walk so much, because if you walk so much, your knee replacement will come soon and all the things.
Yes, sir.
Is there any relationship between?
That's what I was telling you, sir. Because the longevity of these implants are subjected to ideal conditions. But if it's a walking over a straight surface, and it's basically subjecting the implant to cycle, sir. But it shouldn't change drastically. If you're just walking, it shouldn't do much difference. If it's low impact exercise you're doing, it should be fine. Only the high impact extreme movements would cause early wear and tear. But if you're walking, I ask my patients to walk 10 kilometers, 15 kilometers if they can manage, so it's fine.
There may be more strain on the knee joint.
Sorry?
There may be more strain on knee joint.
Yeah. I mean, there is strain, isn't it? So it is trying to balance health with implant. It is taking a car and trying to preserve the tire and parking it in. What happens? Engine goes bad. But if you drive around a lot, the tire starts balding. So you sort of need to find that balance. Whatever is ideal for your physiology, your age, you have to respect it and act accordingly.
Walking should also be limited according to the age.
Age, absolutely, sir. Because I told the protein and the water content changes with age. So if you do the activity of a 30-year-old when you're 80-year-old, obviously the impact on cartilage is much more.
Is there any chances that robotic arm can get malfunctioned?
So yeah, it is technology, isn't it? So it has happened in one of my case where fortunately this happened before I started the incision. The robot just refused to turn on. We got our engineers, everything, and half an hour we waited, it just didn't turn on. So that is why we say robotic arthroplasty should be learned after the person knows to do a conventional knee replacement, joint replacement. It's basically going through primary school, secondary school, high school, and then college. You should have that pattern of learning. You should know the basics. You should know what surgery is before you start using fancy tools. It's not foolproof. Yeah, it can happen. But if it happens in between the surgery, you should be trained to know how to, get out of it. Exactly. So that is the reason training is very important. Thank you very much.
Thank you,
I
sir.
really thank all of you.
Thank you, sir.
Wonderful.
Thank you once again. ಡಾಕ್ಟರ್ ಸಮರ್ಥ ಆರ್ಯ ಯು ಆರ್ ಗಿವನ್ ಎ ಸಮರ್ಥ ಆನ್ಸರ್ ಕೊಟ್ಟಿದ್ದಾರೆ ನಮಗೆಲ್ಲ ಡಿಸ್ಕಷನ್ನಲ್ಲಿ. ತುಂಬ ಧನ್ಯವಾದಗಳು ನಮ್ಮ ಪರವಾಗಿ. ಐ ರಿಕ್ವೆಸ್ಟ್ ಅವರ್ ಪ್ರೆಸಿಡೆಂಟ್ ಆ್ಯಂಡ್ ಸೆಕ್ರೆಟರಿ ಟು ಹಾನರ್ ಅವರ್ ಡಾಕ್ಟರ್ ಸಮರ್ಥ ಆರ್ಯ ಆಸ್ ಎ ಟೋಕನ್ ಆಫ್ ಅಡ್ವಾನ್ಸ್.